This morning, I am very excited to welcome our own chief resident, Dandi Huang. She received her undergraduate degree in biochemistry, biophysics, and molecular biology from Whitman College. She then earned her medical degree from the University of Washington School of Medicine before coming to the other UW for residency. Here, she's been significantly involved in research with the GYN Oncology Division, and in a few short months, she'll be off to Cedars-Sinai Medical Center for a fellowship in GYN Oncology. Welcome this morning. Thank you for joining us.
Okay. Well, thank you for that introduction, Dr. Vizzuto. I just wanted to start my presentation with this quote, which I think is really significant. And this is about the concept of this pool of blood that is vital to life in the chest, and how this Hmong family perceived what the NG tube was doing for their family member. So I actually had this topic in mind for my grand rounds from early in residency and wanted to share a little background about why I chose this topic. I initially became interested in medicine after discovering the fascinating interplay between culture and medicine within my own family. I grew up in China and Japan before coming to the US in 2000 and lived with my grandparents and uncle in China during my early childhood. Here are some of their pictures. Even though I was young, I still vividly remember how hard they all tried to make sure I had no physical contact with my uncle, who is in the right upper hand picture. He would use a tissue or some other form of barrier when touching common household items. He had his own chair that he would use during meals that I was not allowed to touch, and I was never allowed to step inside his bedroom. Outside of the house, he acted like anyone else. Not until high school did I finally realize that it was because he had hepatitis B, which he contracted in his infancy, and they were protecting me from contracting it. My grandmother worked in pharmaceutical research and had a background in the sciences, but social stigma around hepatitis B still exists in China. This realization showed me just how powerful the social aspects of an illness can affect one's actions and inspired me to shift my career goals towards medicine to explore this interplay. So fast forward to residency, and I remember on 2 separate occasions on our inpatient GYN oncology service where I met 2 older Hmong women, both of whom were initially diagnosed with early stage cervical cancer, but were lost to follow-up and returned with much more advanced incurable disease. I remember the long conversations with the families and the frustration that was felt by both the provider team and the family. And these 2 encounters reminded me of the talk I attended in undergrad by the translator who helped with the book, The Spirit Catches You When You Fall Down, which many of you have probably read. And I remember her mentioning during her talk about the difficulty of spreading cancer awareness among the Hmong community due to the lack of both the word and concept of cancer in their language. And it made me wonder just how much of that may have been at play with our 2 patients. Wisconsin has the 3rd largest Hmong population in the US, so I thought I would take this opportunity to talk about caring for our Hmong patients, the intersection between culture and Western medicine. I have no disclosures. So for my learning objectives, I'm hoping through this talk that you'll be able to familiarize yourself with the history of Hmong migration to the US, acknowledge the unique aspects of Hmong culture in relation to health, realize some of the challenges of conveying certain aspects and concepts of Western medicine to our Hmong patients, and identify ways to better communicate with our Hmong patients. For my talk today, I will start by going over an overview of Hmong history, go over demographics of our Hmong population here in Wisconsin, and then talk about Hmong culture and Western medicine, and my findings from questions I asked a couple of our Hmong interpreters that we work with here at UW Health. So in order to understand a group of people, we must first understand their history. The Hmong population is a unique ethnic group with no country of their own. Their roots are thought to have originated around the Yellow and Yangtze River in central China, dating as far back as 4000 to 3000 BCE. They are a part of the Miao people, which is a group of linguistically related people living in China. In their early years, the Hmong were known as industrial farmers and thought to be one of the first to cultivate rice and spread the staple throughout Asia. By the 18th century, however, they began migrating towards southern China due to expanding population of the Han Chinese. Further efforts by the Chinese rulers to suppress ethnic minorities forced them to migrate into the mountainous regions of Southeast China, areas today that are known as Laos, Burma, Thailand, and Vietnam. This is an illustration of the Miao Rebellion that occurred between 1795 to 1806, which was an uprising of the Miao people against the Qing dynasty and stemmed from multiple grievances, including ethnic tension with the Han Chinese. It is important to recognize that the Hmong population in the U.S. are primarily from Laos, which I will talk about more shortly. In addition, there are also multiple subgroups within the Hmong population, and their social structure is organized by clans. Within the Hmong population in the U.S., there are estimated to be about 18 clans. Currently, there are about 9 to 11 million Hmong people living worldwide, mostly in China, and over 300,000 Hmong living in the U.S. Other countries with significant Hmong population include Vietnam, Laos, Thailand, Australia, and France. By the early 1900s, there were as many as 30,000 Hmong living in Laos, which was part of the French Indochina at the time. The Hmong gained more independence as the French and Laotian authorities started allowing them to oversee their own specific issues. However, they were not officially recognized as citizens of Laos until 1947 after World War II. Between 1940s and 1950s, Hmong also became more involved in the politics and military through World War II, as well as France's attempt to reassert its control over their former colonies in Southeast Asia following the World War. Their involvement in the military reached its height with the rising political instability in Laos. And the most important event that pertains to the Hmong population in the U.S. is probably the Secret War. As the political instability in Laos resulted in the Laos Civil War between the Communist Party and the Royal Lao government, President Kennedy also authorized the recruitment of ethnic minorities to participate in a covert military operation against the spread of communism. This is what we now know as the Secret War. Of the 300,000 Hmong that were living in Laos by that time, more than 19,000 men, including child soldiers as young as 10-year-old, were recruited to the U.S. CIA-sponsored special guerrilla units. By 1969, the Hmong participation in U.S. military neared 40,000, and as the war escalated, some Hmong girls were also trained as nurses and medics to care for wounded soldiers. By 1971, the average age of the Hmong recruit was 15. If you were to do the math, these young child soldiers would be in their mid-60s today. The picture on the right is that of General Van Pao, who was a Hmong general who helped President Kennedy. Near the end of Secret War, an estimated quarter of all Hmong men and boys in Laos were fighting against the communist parties. By the end of this war, it was estimated that 30 to 40,000 Hmong soldiers were killed in combat. Another 25 to 3,000 soldiers remained missing, and about 50,000 Hmong civilians were wounded or killed. Thousands of Hmong civilians were also displaced, and I think this quote at the bottom is really telling about the situations at the time. Around the time of the end of the Secret War, a ceasefire and political peace treaty was signed in Paris requiring all U.S. and foreign military powers to withdraw from Laos. Additionally, the Vientiane Agreement was signed, giving the Communist Party control of the Lao government. As a result, more than 120,000 Hmong suddenly found themselves as refugees in their own homeland due to their involvement with the U.S. military forces. Between 1975 and 2015, the Lao Communist regime launched an aggressive campaign to capture or kill Hmong soldiers and families who sided with the U.S. CIA during the Secret War. Thousands of Hmong fled on their own to Thailand, while others went to live deep in the jungle and fend for themselves. The Hmong also began moving into refugee camps organized by non-government organizations before going abroad to resettle. The picture in the middle is that of when they were evacuating General Van Pao and some of the military members, and a lot of others also went there to see if they could also be evacuated, but majority of them ended up just having to go by foot. Between 1975 and 1997, an estimated 138,000 Hmong escaped by crossing the hazardous Mekong River to refugee camps in Thailand. During this time, an estimated 50 to 100,000 people died from fighting, diseases, and starvation. Here are pictures of Hmong refugees traveling by foot and conditions of a refugee camp in Thailand. Discussions about the refugee camp is beyond the scope of my talk today, but needless to say, many of these first-generation Hmong immigrants still carry with them the physical and psychological trauma suffered during the war and the refugee flight after, which has caused many of them to feel betrayed. And this is also important to remember because it can also affect how they view Western healthcare providers. The Hmong are one of the most recent Asian groups to arrive in the United States. The first Hmong family arrived in Minnesota in 1975, and the largest wave came after the passage of the U.S. Refugee Act of 1980. Currently, more than 300,000 Hmong live in the U.S., with Minnesota, California, and Wisconsin having the largest Hmong population in that order. And the most recent wave of Hmong came to Wisconsin in 2004. The choices for areas of resettlement are thought to be guided by efforts to keep their clans intact. The top picture is that of a shaman at a refugee camp blessing those who are about to embark on their resettlement journey. And the picture on the bottom is that of a celebration in Minnesota dedicated to Hmong veterans who fought for the U.S. in the Vietnam and Secret War. Despite their sacrifices, many of these veterans were not granted the same benefits as U.S. veterans until just a couple years ago. Next, I will review Hmong demographics in our state. Just as a side note, the most recent numbers we have are from 2010, and so some of these numbers may be a little bit different today. So there are currently about 50,000 Hmong in Wisconsin. And in 2010, and this map shows the distribution of the Hmong population in our state in 2010, with Marathon County and Milwaukee County having the largest number of Hmong population. Dane County had over 4,000 Hmong people in 2010, and some news articles that I've read from 2018 to now have reported upwards of 6,000 Hmong living in Madison today. Next, the Asian population in Wisconsin only account for 2.3% of the total population. However, the Hmong account for majority of the Asian population in Wisconsin. This is especially important to note when one is looking at studies on Asian Americans in relation to health, because many nationwide studies have focused on large umbrella racial and ethnic minorities, grouping people into white, Black, African American, American Indian, Alaska Native, or Asians, making racial and ethnic minority subgroups invisible. Much of national health research on ethnic minorities have been conducted with Asian Americans as an aggregate group or with 6 larger subgroups, which are Indian, Chinese, Filipino, Japanese, Korean, and Vietnamese, which obviously does not include the Hmong. Other sizable Asian American groups, like the Hmong who have not been disaggregated in national studies, include Pakistani, Cambodian, Thai, Laotian, Taiwanese, Bangladeshi, and Burmese. This is important to keep in mind because these groups are very different and have unique cultural backgrounds, histories, cultural practices, health-related beliefs, education, socioeconomic status, and geographical origins, all of which may result in significant different health outcomes. So about half of the Wisconsin Hmong back in 2010 were born outside of the U.S. When we take a look at their English proficiency, it is important to note that for those who are over 65, over 95% of them did not speak English or spoke English not very well. For the group between ages of 18 to 64, about a quarter of them did not speak English or spoke English not very well. So I reached out to our UW Health Interpreter Services, and they told me that Hmong is a close second in terms of interpreter demand after Spanish. And of the daily 200 appointments here at UW Health that require interpreters, 7 to 8% of those are for Hmong interpreters. These will be important to remember when we talk about the limitations of the Hmong language when it comes to medical terminologies. For education, the Hmong had an overall lower level of education attainment compared to the total Wisconsin population, and about a third had no schooling completed back in 2010. Both Hmong and male and females tended to have lower income than the general Wisconsin population. And on some studies, it was reported the average Hmong household income is also much lower than the general Asian American household income. Other studies have also reported that the Hmong may have the highest poverty rate among all Asian Americans. So, in order to understand Hmong health disparities and challenges, we also need to first acknowledge their culture. And this part of my talk would not be complete without mentioning this book, which many of you have probably read. This book has been widely incorporated into many medical school curriculums around the country as a hallmark for cross-cultural communication. It follows the Lee family and documents the cultural collisions in their experience with the Western medical system as they navigate their daughter's epilepsy diagnosis, which the family perceives as an illness associated with the soul leaving her body. Due to these understandings, they were unable to follow their Western doctor's recommendations, and Leah ultimately had a grand mal seizure that would not stop, developed septic shock, and was brain dead by the age of 4. She, however, went on to live for 26 more years at home in a vegetative state and passed away at the age of 30, being cared for by her family all those years. These are a couple of quotes from one of the pediatricians who cared for Leah when she was first diagnosed with epilepsy. The Hmong have a patrilineal culture, and their identity resides in the family, clan, and community rather than the individual. They emphasize relationships and have deep respect for elders and traditions. As previously noted, there are about 18 clans among the Hmong in the U.S., and the clans can typically be identified by their last name. Clan members often viewed each other as brothers and sisters, and traditionally, the clans provided social services to its members and had their own skilled persons who served as healers, teachers, marriage brokers, etc. Another interesting aspect of the Hmong culture is that their written language is relatively young and was not developed until the 1950s, which means that majority of the Hmong living in the U.S. may not be literate in Hmong. Furthermore, increasing number of second-generation Hmong Americans are less fluent in Hmong, which is an important implication when you are using a younger family member to help communicate for older Hmong patients. Additionally, men traditionally had higher status in the Hmong society. However, Hmong women in the U.S. have also gained increasing power. And though this changing gender status is positive, it has also been associated with divorce and higher risk for domestic violence. Finally, birth dates for those Hmong who were born in Laos may only be approximate because birth dates were based on seasons and not calendar years there. The traditional Hmong medicine is practiced as a part of vast cosmology with animistic beliefs where a visible world and an invisible world of spirits coexist. Shamans play a large role by bridging these two worlds and are responsible for duties similar to that for a psychologist, doctor, and a minister. They believe that a person has upwards of 12 souls, all of which are important to life, and illnesses can occur when any of these souls or ancestral spirits become compromised or separated from the body. Shamans can intervene in these situations, performing rituals like the one illustrated here. These strings are tied by shamans to restore the soul, to hold intact alive souls, and shield a person from evil spirits. If a person was seriously ill, the strings may be also tied to the ankles, waist, and neck. It is important to also note that this string tying ceremony may also be performed as blessings at events like weddings, and different colors of strings may represent different meanings. Unfortunately, when these practices are not known, hospital staff will often cut these strings off of the Hmong patient due to concerns about cleanliness, safety, and venous access. And these actions, unfortunately, may also have contributed to Hmong distrust of Western medicine when they first arrived in the U.S. Additionally, some Hmong people may also feel hesitant to undergo surgical procedures due to the worry that they may lose their soul while unconscious under anesthesia. They may worry that the removal of a body part may clash with the Hmong belief in reincarnation. Thus, for some patients, after any general anesthesia, it may be important to have a soul calling ceremony in the operating room to recall this lost soul. If any of these soul calling rituals fail to bring back the soul, then it is thought that the patient's condition may worsen and they may even die. Due to these traditional beliefs, there may be difficulty understanding certain Western concepts of disease processes and transmission. And lastly, home remedies and herbal treatments are still widely used and may still be the primary preference despite knowledge of Western biomedicine. These traditional Hmong health beliefs and practices are important to keep in mind when understanding when or why a Hmong patient may seek care from a traditional healer versus a Western care provider. Dr. Lohr and her colleagues here at UW-Madison conducted an exploratory qualitative study looking at this decision-making process among Hmong people who had limited English proficiency. One of the key factors that they found influenced this decision was classification of the illness into spiritual or non-spiritual illness, which was also associated with the visibility of the illness. When there was visible illness, they tended to seek care from Western health providers. However, if the visibility was pallor alone, they often tended to present to a traditional healer as that was associated with the loss of soul. For invisible illnesses, their decisions were based on the speed of symptom onset, duration of symptom, severity, and perceived precipitator such as a spiritual cause. Vague symptoms like fatigue was often linked to loss of spirit or soul, and they tended to seek care from traditional healers first. Additionally, pain was the most important invisible physical symptom, and they often focused on severity and ability to identify a perceived cause in order to decide where to go. Often, they would not present to the Western healthcare provider unless the pain was severe and abrupt, and if they could not make any connections to a cause. When the pain was not severe, they often classified it as having a spiritual cause and would present to the traditional healer. Another key factor that influenced their decisions was effectiveness of treatment, which can go both ways, causing someone to change from a traditional healer to the Western care provider or vice versa. However, it is important to note that effectiveness may also be synonymous with a quick response. Therefore, if a medication is not perceived as providing a quick relief or result, they may switch to seeing a traditional healer. This is especially important to remember for chronic illnesses where medications are used to control a condition and may not have an obvious perceivable effect immediately. In this sense, it is important for providers to ask patients if they have considered using other treatments and to reconsider what they may classify as non-compliance, as this non-compliance for the Hmong patient may actually just be an act of exploring all of their options. Another interesting theme that this study and other focus groups also mentioned was the physical evidence of illness. Most of the participants in this study reported that after a diagnosis was made by a Western care provider, if the provider could not provide a picture of the condition, specifically in the form of an X-ray, then it would lead them to switch over to a traditional healer. One of the male participants shared in the study that he was diagnosed with a gallbladder issue in the emergency department, but because there was no X-ray to prove it, he decided to seek care from a shaman afterwards. Another focus group study led by Johnson in 2002 looked at Hmong health beliefs and experiences in the Western healthcare system. They found that many of the participants in the study had no exposure to modern medicine or education in Laos, and that they had no idea what organs were in the body or how these organs function. Most significantly, many medical and anatomy terms in Western medicine had no terms in the Hmong language, and therefore they had difficulty understanding when providers told them they had a disease or a malfunctioning organ. This is actually a recurrent theme that I came across while preparing this talk today, and will be mentioned later again as I go into findings from my interpreter interviews. Additionally, the idea of controlling a chronic illness was also foreign, as most symptoms that were viewed as illnesses back at home were acute. And one man described this as you either got better or you died. Finally, many expected Western medicine to have noticeable, immediate, and powerful effect. So if that did not occur, or if there were adverse side effects, then they would often stop taking the medication. However, the Hmong also prioritizes presenting themselves in a positive light, so they may not always disclose that they stopped the medication, and may also say yes to be respectful to the provider, even when they do not understand exactly what was said. Not surprisingly, the socioeconomic and social-cultural differences have also manifested themselves as health disparities. The Hmong have higher rate of infection-related cancers, such as cervical cancer, hepatic cancer, gastric cancer, nasopharyngeal cancer. Specifically for cervical cancer, patients also tended to be diagnosed at a later stage and had higher mortality rate compared to all Asian Americans and non-Hispanic whites. Some studies out of California and Minnesota on screening have also reported screening rates as low as 30% for mammograms and 27% for pap smears. And lastly, the incidence of chronic illnesses are somewhat limited because of the lower utilization of preventative healthcare, as that concept is also new. To delve a little more into breast and cervical cancer screening, there was another study done here at UW-Madison looking at barriers to these screening tests. This was a study of 16 women, and there were multiple themes that came out of the interviews. One theme was that not only is there no equivalent Hmong word for cancer, but many of the women voiced uncertainty about the causes of cancer and also the Western treatments for cancer. Furthermore, many had a fatalistic belief about cancer, and the concept of cancer stages is foreign. Most important probably is the embarrassment surrounding discussion about women's body and having exams involving private parts of the body. Not only are they embarrassed to discuss this with the provider, but they also consider it embarrassing to talk about with other women in the community, as these screenings are considered a personal matter. Finally, the lack of competent interpreter was also mentioned. I think this is very interesting because we take interpreters to be communicating exactly what we're saying. And it also shows just how different the Hmong language can be from the English language. I read in one instance when there was a new cancer awareness program that it took almost 20 minutes just to explain what the cell meant in order to start talking about what cancer was in this community. So if cancer screening and awareness are hard to achieve, then how do we actually talk to our patients about cancer diagnosis, especially as those patients with new cancer diagnosis tend to be the older first generation Hmong. One study that looked at Hmong attitudes about cancer recommended that providers use professional interpreters over family members. This is important to remember as there are so many biomedical terms that do not exist in the Hmong language, and many of the second generation Hmong may not be fluent enough in Hmong to adequately describe what is being communicated to their elders. In order to help understand the concepts that do not exist in the Hmong language, diagrams, audio, videos can also help. Additionally, identify supportive male family members who would advocate for Western medical practices may also be helpful. It is also important to effectively communicate with the males and elders who will most directly influence the family health care perceptions and practices, though a not yet published study has also shown that at least for breast and cervical cancer, families are starting to defer back to the women for decisions. Finally, it was suggested the adult son or daughter should help coordinate care for the elderly, with the caution that when a woman coordinates the care, if there was a poor outcome, then they may be at risk for becoming an outcast in their clan. Next, I will talk about a topic that is near and dear to all of our heart, which is prenatal care. Based on the 2010 Wisconsin Hmong demographics, our Hmong population tended to have larger families, higher order number of birth, and lower percentage of pregnancies in which prenatal care began in the first trimester. Early in the resettlement period, they also looked at prenatal care among Hmong in Minnesota. They found that then only 16% had initiated prenatal care in the first trimester, and about a third had delayed care until the third trimester. One of the clinics in Twin Cities looked into why that may be, and some of the barriers they found were that women did not understand why certain procedures were being done throughout their prenatal care. They also found pelvic exams to be unacceptable and did not understand the rationale for them. There was universal resistance to cervical exams due to the shame associated with the exam, trauma from refugee camp, and this historical belief that exploration of women's pelvis with unsterile hands can cause life-threatening problems. Finally, they also had reported inconvenient clinic hours. To better understand these findings and provide culturally competent care, we need to first be familiar with some of the traditional Hmong birthing processes. In Laos, pregnancy was recognized around 5 months, and women typically would work throughout their pregnancy until labor began. They were also taught to be stoic about pain and to remain silent throughout labor, as it was believed that noise may actually prevent birth. Labor was unattended and the husband often helped deliver the baby. But if the labor was becoming difficult, a shaman would be called on to perform rituals and provide herbal remedies. Women also allowed themselves to rest after birth and would engage with their newborn when their breast milk came in. Finally, pregnancy was also considered a heat-losing event that needed to be counteracted by consuming hot foods. This California State University study looked at barriers to prenatal care among 173 men and women, and they found that for both Western healthcare in general and prenatal care, the lack of cultural understanding, not receiving expected care, communication issues, and trust were all common barriers after logistic reasons for not seeking early prenatal care. Another interesting finding that the study reported was that how the woman perceived the provider's views on shamans also affected when they sought prenatal care. When I was preparing my talk and discussing it with Dr. Lore, whose studies I've mentioned throughout this presentation, she mentioned the same sentiment as well about the importance of creating a safe and open environment to discuss these cultural desires, especially since the Hmong really emphasize holistic health, including their spiritual health. One thing that she told me that I found particularly fascinating was that there are actually certain Hmong elderly women in our community who will perform the equivocal of our external cephalic version and Hmong women would often go to them when they have a breech baby. However, this is rarely disclosed to their Western OB providers because they don't know how it'll be perceived by the provider. Then last but not least, I thought it would be interesting to compare what our Hmong interpreters thought about this topic in a comparison to the information I've gathered from prior studies. So I reached out to our UW Interpreter Services team and was able to get 2 of our contracted Hmong interpreter to answer the following questions. 1, are there certain concepts in Western medicine you find difficult to communicate to patients or that you think Hmong patients have difficulty understanding? 2, specifically in women's health, such as routine gynecology visits to obstetric care, are there topics, concepts that you find difficult to interpret to your patients? Again, in women's health, are there aspects of Western medicine you have noticed Hmong patients feel uncomfortable about? Specific to cancer diagnosis, prognosis, and treatment discussion, are there concepts in West medicine that are harder for older Hmong population to understand? What are some cultural differences, if any, that you see between the Hmong culture and Western medicine that affect how well we as providers communicate and care for our older Hmong patients? And finally, what changes do you wish to see among healthcare providers, whether it's at the individual or system level, to improve our care for the Hmong patients? For the first question, one of our interpreters said power of attorney, living will, nursing home, hospice, insulin, cell genes, chromosomes, or DNA as some of the concepts that are very hard to communicate. I think this is really important because these are things we talk about every day. And our resident didactic today after this is actually on OB genetics. So I think it'll be interesting for us residents to think about how we may explain these concepts to non-English speaking Hmong patients using only descriptive language. The second interpreter also answered molecular concepts and added organs and their functions, as well as hormones, which I think is really important to acknowledge as a medical provider. I think the comment about hormones is especially pertinent to our field because we talked about it often in clinic, whether it's about PCOS or on the labor floor when we talk to patients about starting Pitocin. For my second question, the first interpreter responded that private body parts, diseases, and family planning practices are hard to interpret because these are private matters that are usually only discussed in an indirect manner. To say the word vagina or penis directly can be seen as unlearned, insensitive, or ignorant, and it would be better to say private part. For us, especially when we are often talking about reproductive organs, it makes sense that a patient may not fully understand what is happening or what we're trying to communicate if things are communicated indirectly and there are no direct anatomical or medical terms that can be used. Dr. Lore also told me that this also happens when Hmong people talk about different procedures and their experiences with procedures. And so sometimes similar procedures can be mixed up. The second interpreter took this question a little bit differently and talked about his own kind of barriers as a male interpreter caring for female Hmong patients. And he actually thought that perhaps the presence of a male interpreter alone may be a barrier because the female patient may not feel comfortable fully expressing her concerns through them. which I think is also pretty relevant to what we just talked about in the last hour. For this third question, it was interesting that both interpreters mentioned family planning and contraceptives. And I think this is really key because we often ask about this at our annual visits, our prenatal care, on labor and delivery, and on our postpartum floors. And we may need to be creative in the way that we bring this topic up. Let's give you guys a little time to read these. Next, moving on to concepts on cancer diagnosis, prognosis, and treatment that are hard for older Hmong patients to understand. Similar to what I found researching for this talk, the first interpreter said that just the word cancer is difficult for older Hmong population to understand, and that pictures and analogies can help. The second interpreter's answer was a little more broad and in a way more significant because he mentioned that diseases and infections are used too broadly, which can pose a challenge to interpreters. He also mentioned that pictures can help patients understand body parts that have no Hmong terminology. In terms of cultural differences that can affect communication between providers and Hmong patients, the first interpreter mentioned that pills versus herbs is a big barrier in treating older patients. Dr. Laura also told me that sometimes it can be helpful to mention that the medications we have in pill form originated from herbs and plants, which can help them seem more acceptable to our first generation Hmong patients. The second interpreter listed all these things as the cultural differences that can affect provider communication. I think within this, the point about guaranteeing results over just trying to do your best can be very tricky because we can never guarantee an outcome for a treatment that we are proposing. And so I think we need to also be creative about how we counsel patients about, or among patients about those outcomes. Finally, I asked them what they think we can do at the individual level or system level to improve our care for Hmong patients. The first interpreter said, recommended that we really spend time educating patients and help them understand how their body works. I think this last part is very important because we can be quick to refer patients to specialists, which in someone who is new to the Western healthcare system, that can actually be pretty overwhelming to have so many different appointments and so many new faces. And I think that sometimes can also increase the risk for things to be lost in translation or for there to be more cultural issues that arise as well. The second interpreter said that he recommends that we recognize that there are clearly different and opposite ways of thinking, and realizing that seeing these differences can make us more compassionate, patient, caring, understanding, and engaging. So now to kind of summarize my talk, here are the take-home points that I think can help. One is that many of our first-generation Hmong from Laos may still be living from trauma from the secret war and its aftermath, and that can affect their perceptions of Western care providers as well. When looking at large-scale health studies on umbrella groups of Asian Americans, it is important to remember that the numbers and outcomes that are reported may not represent Hmong Americans. It's also important to acknowledge the linguistic and cultural barriers and differences to help build trust and overcome disparities. Asking for their perspectives and understanding, as well as expectations, can promote better communication. Recognizing that even professional interpreters have difficulty interpreting medical concepts, as the Hmong language has limited vocabulary or descriptions for the biomedical model of health. And that when we are communicating to the patients, descriptive terms and layman terms are easier to translate than more technical terms. Visual and audio can also help improve communication, especially for concepts and words that do not exist in the Hmong language. Teach-back methods can be helpful to really ensure that we communicated well to our patients. And remembering that the Hmong traditional health is holistic, including spiritual health, and to create an open environment where they feel comfortable mentioning those aspects. And finally, in terms of this talk in general, it's more focused on Hmong patients who are practicing traditional medicine, but that does not represent all of the Hmong Americans. So to end my talk, I wanted to show this quick video. This is at a hospital where Leah Lee from The Spirit Catches You and You Fall Down was treated. And they talk about their experience of incorporating shamans into their everyday care.
The Hmong people do not trust the doctor. They'd rather go to see the shaman first.
There was a fear of the hospital. So a lot of times when they would finally come to the hospital, it was at a crisis.
Merced is a small town. We have more than 7,000 Hmong living in Merced County since 1976.
When they first arrived at Merced, of course, they didn't know anything about our culture and we didn't know anything about theirs. And so there was a challenge to communicate. Hmong shaman will tie strings around the wrist of the person that they are giving a ceremony to. Our staff would cut them off.
The misunderstanding really caused a lot of issue in our community.
We wanted to bring the shaman into the hospital because Dignity Health understands that healing is looking at the person as a whole. It's body, mind, and spirit. So the Hmong shaman are spiritual healers.
So we decided to have this orientation class for the shaman.
We wrote a policy, actually a hospital policy, and it identifies 9 ceremonies in it that the Hmong shaman can come into the hospital to do for the patient.
We not just teach the shaman, but we do teach the resident physician to learn more about the traditional belief, the spiritual healer, to listen to them to see how they do it, how do they help the patient. I have seen a lot of changes. It really makes the Hmong community feel better, open it, and talk about it, because they used to put it under the table, don't want to share to anyone.
Cộng lúa thia, một cận đó lúa thia, bé thì bỏ cái trà, bé cho nhau chạy sĩ bé chỉ bỏ, cho cái trà.
Okay.
The Hmong.
So with that, I would like to thank the entire Department of OB/GYN here for the last 4 years. My entire class couldn't have made it here without all of you. Dr. Lore, who helped me with this talk, the UW Health Interpreter Services, who also helped me with this talk, my fiance Alex for putting up with me these last couple weeks as I prepared this talk, and my family for helping me get to where I am today. These are my references, and I'd be happy to take any questions.
Dandi, that was fantastic. Thank you. So any questions?
It looks like Margaret has a question in the chat here. She writes, if a Hmong woman presents with her son, do we ask who to direct questions to, or do we direct questions to the patient, which is what we've been trained to do? Should we ask if a shaman should be present so we can work collaboratively?
Yeah, based on what my conversation with Dr. Laura, I think those are all great questions, and I think those definitely are worth mentioning to create that open, welcoming environment to understand what they see as important in their care. Yeah.
Great. Do you know, Dandi, if there's any like what it takes to be a chaplain? You know, like can shamans become like chaplains in the hospital, or is that, I don't know if you learned anything about that from the talking to the interpreters?
Yeah. Not like specifically, but I think because they do kind of also carry the role can carry the role in the community as like a minister. I think if the Hmong patient thought they would feel supported from like the spiritual health side of things with their shamans, I could see that. I could see them carrying that role. And I never reached out to like the chaplain services, so I don't know if they may also have like a shaman on call or something for our large Hmong population.
Dandi, this is Katie. That your talk was awesome. A couple of things you really shed light on for me. When I was in Pittsburgh, we had a fairly decent Hmong population that would present to labor and delivery into our pregnancy clinics, and I can particularly remember having conversations about gestational diabetes, where you would literally do an entire visit with an interpreter, and the feedback that you would get from the interpreter was like nothing you said made any sense to them. And we as residents always blamed it on, oh, we must have gotten an interpreter of a different dialect. Right. Like they don't understand what the interpreter's saying, but you've really like brought light to a really different perspective that's super helpful to understand. And maybe it was just also the interpreter, like how they were able to explain what we were using in medical terminology. So super fascinating. I just was curious. I can't even recall having a patient requiring a Hmong interpreter. So while I might have Hmong patients that I don't realize are Hmong, I'm just curious what your perspective here is. My practice just like in a skewed location, or are many of our labor and delivery patients just proficient in English where we don't have an interpreter and may not recognize that they're Hmong?
That I don't know, because I've definitely seen patients at the Arboretum clinic who have required a Hmong interpreter for like younger Hmong patients for routine prenatal care or like GYN consults. So I don't know if there's a difference in terms of like what clinics they're ending up at.
That very well probably is the case then.
Yeah.
Dandi, this is Laurel. This may sound so much in the distant past, but Brian Spencer and I, about 8 years ago, worked with a tenured Hmong professor in the history department at UW to develop a translation thing regarding consent for labor and delivery. Kim Miller was my contact person on labor and delivery. Is that working at all, or is that just history?
I have never seen that. I actually, like, earlier this year, I think I was talking with maybe Dr. Watlett about that specifically, because all our consent forms are written, resources are only in English and Spanish. And so there are a large number of our patients who we have nothing to give to. So another thing that Dr. Laura said she's actually doing is she's actually working on a grant to develop like a Hmong dictionary with like visuals and things specifically for like medical terminology that she's hoping to roll out this summer. So that's something to keep an eye out for.
Wonderful. Well, I think we're at time here this morning, but thank you, Dandi, for presenting, and this was a wonderful presentation, and everyone please enjoy the rest of your morning.